we welcome Professor Nyakale. She is Associate Professor and like head at like, SMU and at George Macquarie Hospital. She has published various articles and book chapters. Yes, and she was instrumental in large parts of the curriculum development, and she serves on various boards. Yes, and she's got a vast teaching experience. Welcome, Professor Nyakale.
Thank you very much. When I was younger, I used to run fast, so this time I tried and they caught me. But I really apologize. I actually thought we were running, they told me we were running like almost an hour late, so I thought it would be a good time to just breathe a bit, so my apologies, I'm sorry for that. Okay, so mine is just to talk about the applications of imaging, or nuclear medicine imaging in infection. So I think we know that at this point, the World Health Organization has shown that infection is one of the leading causes of death globally. And in low-income countries, unfortunately, lower respiratory tract infections such as TB are some of the leading causes, and they're in the top 10, as well as HIV. So it's a problem in that it's very challenging. It's a very challenging clinical diagnosis. And with the use of antibiotics, with the rate of use of antibiotics, then people are developing resistance, which is causing an even greater threat to global health. So what would assist would be early diagnosis, which would be critical. The gold standard is culture. Unfortunately, that takes a long time. And normally with infection, it's quite an urgent issue, and there isn't that time. Treatment monitoring is also quite essential and would help to reduce morbidity and treatment failure. So the role of imaging ideally would be to help localize the site of infection, and which can assist if the infective site is not known, to guide biopsy, can assess the extent of the infection, monitor treatment response, prognosticate in certain cases as well. Ideally, it would be great if we had radiopharmaceuticals or imaging agents that were able to discriminate between infection and inflammation. And I think that's what the work is going towards. In terms of imaging techniques, I'm not going to talk about structural imaging, but I just had to show it. But you know that mainly the starting point would be X-rays. And then from X-rays, then they can determine whether you go for MRI and so on. But generally, that's the starting point. You can do MRI, CT, as well as ultrasound. That ultrasound image is not related to the spine. It's actually an abscess in the abdomen, but it's just to demonstrate the pattern. And then with functional imaging, the main agents that are being used in infection imaging, even today, is MDP white cells. Gallium citrate, not so much. I think it's not as easily available as it used to be. But FDG is used quite a lot. These images are just to demonstrate the different traces that we can use. Nuclear medicine is great in that we use radioactive probes that can target either the microbes or human cells. So in doing so, then we can look at the different pathophysiological areas of infection and image them from different aspects, depending on what we're looking for. And then for hybrid imaging, that's even better in that with the fusion of anatomical imaging as well as our imaging, is that the diagnostic accuracy has increased quite a bit. And it helps to pinpoint and localize the pathology. It's more precise in terms of resolution, and also helps with attenuation correction. Some of the infection imaging, the main ones, the common ones I've already mentioned, you labeled white cells. Let me skip that. But this slide is from, well, I didn't write the article there, but anyway, I can give it to you if you want. I've actually mentioned it in one of my earlier slides. But it just shows you the different radiopharmaceuticals that are commonly used. My eyesight is a bit not so good now, but anyway. as I mentioned, that we have MDP. MDP, it's very sensitive, as we all know, but generally, if you're going to use it alone, it has to be in bone that has not been infiltrated, because then the problem with MDP is that it goes also to bone that is turning over. So even if you just have an insult, then it will show uptake. And then you've got white blood cells. That's a good tracer. The unfortunate thing is that you have to handle blood and, to label that. And then you've got gallium citrate, which I've mentioned, and FDG, which then also looks at the metabolic processes that happen with infection. So these are just some of the experimental drugs radiopharmaceuticals that have been mentioned that are actually looking at targeting specific pathogens, which would be great if they somehow eventually made it to the market. You can see, I'm not going to mention any of them, but you can see that they can target like your gram-positive and gram-negative bacteria, which would be great. I mean, if you could be able to detect exactly what the pathogen, or at least close enough, what the pathogen is through imaging, then I think we would have come a long way. So that was just to indicate. So this is quite a big topic, and my role here was really mainly to see where we are now. That was just to, like, what are we doing in terms of infection imaging? So I just looked at some of the common indications for nuclear medicine for infection imaging. So I didn't go too much into the new things, but mainly what we are doing and what is the general protocols. So I've mentioned already that when you have, for osteomyelitis, if you have non-violated bone, you can just do a bone scan. And with SPECT and SPECT-CT, that usually can give you quite great information. But in violated bone, then you have to add on to your bone scan. You can either do white blood cell imaging with bone marrow, or else, if you still have access to that, you can do gallium-67. So this is the ACR appropriateness criteria. I've actually included quite a lot of them, and I thought it would be a nice way for, especially if we don't know which direction to go, but for us to actually just look at where we fit in terms of osteomyelitis and other infective processes. So what they recommend, generally we fit in to areas where the normal, like if you have an X-ray and the X-ray is normal, that's generally where we fit in. But if the X-ray is already abnormal, then we kind of are not really given a role in terms of imaging infection. So in suspected osteomyelitis, you can see that it's not even usually appropriate, we're just under maybe appropriate. It's something that tends to happen with nuclear medicine. They always come to us when they're a bit stuck. So you can see that if you have normal X-rays and you still have a suspicion, or at least the clinician still has a suspicion of osteomyelitis, then they may do 3-phase bone scans only in the area of interest. They can do the bone scan with white blood cell imaging, accompanied with colloid imaging, and FDG imaging as well. So all these can be appropriate. However, you can't do a white blood cell scan on its own. And then in bone where there's been surgery, there's been surgical hardware, then the X-ray is not really giving much information, and they're either normal or not clear. That's where we then start becoming a bit more appropriate, and then we can come in. And normally you'd do a 3-phase bone scan, and you'd also add on and do a white blood cell, as well as maybe colloid imaging. FDG is also one of the recommended ones. But in that case, and this one, you would never do bone scan on its own, as I've mentioned. So this is just another one. The indications are also similar. So we may be appropriate in these areas. And then when it comes to periprosthetic infections, if you look at FDG versus white blood cells, so for periprosthetic infections, FDG has been known to be a bit unspecific, because when you have chronic inflammation because of the prosthesis, or else if there's a synovitis or even aseptic loosening, then it tends to have increased uptake in that area, especially if it's in the knees. So previous studies have indicated that white blood cell imaging is still, with bone marrow imaging, is still the best way to go, rather than FDG. And I think most of you have seen this slide before. It's from Palestro. It's quite an old one. And if you look at it, you can see that in most of the cases, FDG does get it wrong, unfortunately. In the first case, it's a 9-month-old cemented left hip prosthesis. And with the FDG, if you look, okay, hopefully you'll just see on your own without me pointing. I'm scared to point. Where's the point? Okay, never mind. I'm just going to leave it and hope that you can see what I'm talking about. But if you look at the left hip, there's FDG in the neck of femur, all right? And then you see the FDG is the first images on the left, and on my left anyway. And then if you look at the white cell and the marrow imaging, you can see that there's actually uptake in the white cell where the arrow is. This is an A, whereas it's cold on the colloid. I think if at this point, I'm assuming that we know how to interpret the white cell versus colloid, because white cell, when there's uptake on white cell and there's photopenia on colloid, then we regard that as an infective process. So in B, similarly, you've got uptake in the acetabular component as well as the hip prosthesis in the head. And if you look at the white cell as well as the sulfur colloid, they're actually negative. So in this case, you've got FDG uptake, but there's no infection. So it's not very clear, and these are the hips. And then with the knees, similarly, you do get a few mistakes. In C, you get synovial uptake with FDG, which on the other imaging is actually, you can see some incongruence. You can see the white cell. Let me just orientate myself. The femoral component was a bit loose. So if you look at the white cell and bone marrow, there's incongruency. There's activity in the, if you look at the left knee on this side, on the medial aspect, you get white cell uptake, whereas you don't get it on the other image. And then you get similar problem with D, where you get uptake with FDG, but nothing on the other ones, which means it's getting it wrong a few times. But in this case, with osteomyelitis of the diabetic, osteomyelitis of the foot in diabetics, to be able to assess, these things are always evolving. So with more studies, you get just better results. I guess it also depends on how the studies are done. But in this case, the initial finding was that FDG has low diagnostic accuracy. But with further studies, as with the study by Laurie et al., it was actually a meta-analysis of quite a number of patients. You can see that in this case, the sensitivity was actually 89% in a patient with a diabetic foot. And FDG, they quoted that it's performed for evaluation of the diabetic foot and has generally defined the presence of focal uptake. So if it's focal uptake for localizing to bone, as positive for osteomyelitis. So it's actually just as good. The only thing is that you cannot have SUV cutoffs. That's the only part where people are always looking for this. The cutoff is this much, the cutoff is that much, and that you generally cannot do with such. So if you have no ulcer, then your 3-phase bone scans and FDG can still be indicated in diabetic foot. And if you do, sorry, okay, I don't know how to go back. Yeah, so whether you have an ulcer or not, you can still have certain aspects where you can use these imaging modalities of ours. And then with fever of unknown origin, I'm not going to define it, but it's persistent fever that goes for a long time in an immunocompetent, a person that's not immunocompromised. The role of FDG is, according to the recommendations, is mainly in pediatric patients, but then I think we use it generally in all the patients if the indication is as such. White blood cell is only recommended if the patient has a good neutrophil count. So this is a Whiskas box plot from systematic analysis by that group. I'm afraid to say the name. But they also saw that with fever of unknown origin, FDG had a mean sensitivity of 84%, specificity of 61%, helpful, positive and negative predictive value of 80 and 67 respectively, and accuracy of 76, as well as helpfulness of 61%. This is an example of a 13-year-old patient that had a liver transplant at age 10. And at age 13 then presented with fever of unknown origin. And on FDG, you can see there's a focal uptake at the stent. The patient had a liver transplant, as I mentioned. And you also see the uptake in the liver there, which was found to be the infective processes. 5 minutes, oh my God. Okay. Okay, I'll try and be done in 5 minutes. But anyway, nuclear medicine imaging in classic fever of unknown origin, this meta-analysis by Takauchi et al., they also found that the diagnostic accuracy or impact of diagnosis and management helps with patients. It's actually better than the other imaging modalities in nuclear medicine. So FDG was found to outperform gallium and white cell imaging, as well as, FDG PET-CT, as well as FDG on its own. But I think we all know that FDG PET on its own without the CT can be a bit problematic. Okay, I still have quite a lot of slides, so I will really just jump through. But we do have a big role to play in infection of in cardiovascular infection. This is a very, it's very difficult to diagnose the infections, and because the symptoms are non-specific, and unfortunately the morbidity rates can be quite high, morbidity and mortality rates. But our role in infective endocarditis, I think it's quite established. You can even with gallium-67, one could actually assess infective endocarditis, but with white cell, I think that the role is even better. This is an example of a patient with aortic endocarditis, had a transaxial SPECT-CT done, and you can see there's a focus there in the mechanical prosthesis, which was infected, yeah. And then some of the complications you can also pick up with white cell imaging. You can see that there's emboli that go to the lungs. In the top images, the middle images, the B images, it's emboli to the spleen. And then in the bottom one, it's even to the spine, and it's quite extensive. Yeah, so let me skip the slide. It's essentially saying the same thing. This one is also not that important, but FDG is also quite important in infective endocarditis. So you'll be able to pick up, but the trick with FDG, because we all know that the uptake in the heart is quite hard, is that your preparation has to be really, detailed and on point, otherwise you may miss it. And FDG is also able to pick up the complications. The limitations are obviously the physiological uptake. If there's surgical inflammation or any other pathologies, then you may miss it, or the size. And it also is good in monitoring treatment. If you look at this patient, although the lesion looks like it's better, you can see there's a lesion just behind the valve. If you can, yeah, I'm so afraid of this thing. But anyway, you can see there's uptake behind the valve, which is not there. But then unfortunately in the later images, then you get a regurgitation continuing, so you've got pleural effusions that are forming. So, but you can see that you can monitor the therapy. And then again in TB pericarditis, this is actually an image that I saw from an article by Lawal et al., where they could demonstrate pericarditis in a patient, in a 16-year-old male. And then in peripheral vascular system, one can also look at graft infections. Again, we can use the same radiopharmaceuticals that I've been speaking about. I think that's just the way it goes now. And then with FDG, the issue is that I think if it's focal, then it's a bit more accurate. However, if you have more diffuse uptake, then you can really not tell whether it's infected or not. All right, so, but if it's focal like this one here, then you can almost confidently say that you have found the cause. I've got 1 minute. Okay, so pulmonary infections, I think that was gonna be my main talk. I didn't write a lot on it, but I thought this is quite important, because this is one disease that is really a problem for us. This is an image also from the article by Lawal et al., which shows a patient that had defaulted treatment and eventually then developed these cavitatory lesions. which could be picked up with FDG. So the role of FDG in TB, it's still difficult to distinguish between TB and malignancy. However, you're able to still monitor treatment, find extrapulmonary disease, and also with resistant TB, one can pick it up with FDG. And this is another article by Ankara et al., who showed that one can use FDG also to monitor fungal infections in the lungs. And you could see that there was an impact on treatment in that they could change the treatment when the patient was recurring and not responding. So that's it, I made it. Yeah, I wanted to mention a few other traces, but I think I'll stop here for infection imaging.
Well, thank you so much for your eloquent review on this in vogue topic.
And thank you for your forgiveness.